kind introduction. Also, hello Maurizio for this exceptional introduction to this very important topic. Now, when I was asked to present here the topic when to extract, when to place, and when to restore, I accepted immediately because I spent with my team almost 20 years of time on research, preclinical and clinical. So I think I start with this. Now, this is an exceptional success story of the ITI because ITI made tremendous contributions to the knowledge of this clinical topic. And you see we have had 4 consensus conferences in Gstaad, Stuttgart, Bern and Amsterdam, where we published then recommendations based on the systematic reviews to help the clinicians, meaning the ITI members and fellows. Now we have heard Lucy, and Lucy is a little bit confused and she's scared, and I don't want to repeat how critical it is. You see, it's a very complex case because she's young, good looking, has a high smile line, and therefore we have to be very cautious. Now when we go to these ITI consensus meetings, 2003, 8, 13 and 18, we added knowledge based on very important publications. One was this famous paper by Maurizio Araujo on post-extraction reach alterations due to bundle bone resorption. And we defined the placement protocols, we defined the risk factors, selected then the selection criteria, and of course also the loading protocols. And that really helped us in this graph I want to show you. This is from the ITI treatment guide number 3. We published in 2008, Stephen Chen and myself, and you see all these factors will influence the outcome of a case like Lucy. And you see one is larger than the 3 other ones. That's the clinician. That means that's you, because you actually analyze the patient, all the risk factors involved. You have then the chance, different treatment options, and you see we have different placement and loading protocols. And for each specific surgical procedure, you also have to select the biomaterials. That means the implant type or then the bone augmentation material. Now, when you look at this one now, we have had these placement protocols starting in 2004 published, and the loading protocols, you see, by H.P. Webb in 2009. It was very logical then in 2018, the Amsterdam meeting, that these 2 protocols have been combined. You see, that means we have now the so-called type 1A or type 4C, whatever, and this paper by Herman Gallucci analyzed the existing literature in 2017 and 18, and you see the green color shows the well-documented procedures, yellow clinically documented, and red is not documented at all. So I think that shows that, of course, we have to be very cautious what treatment approach we select to satisfy the expectations of Lucy. So when you look at these 5 cases I treated in the past 3 to 4 years, these are all kind of Lucys. Each time a tooth has to be extracted, and they are all different. It's very important to understand. And you see that I made in all of them a cone beam CT to see what option will be the best to satisfy the demand of that patient. And the take-home message here I want to give you, if you want to go for immediate or early placement, it's important to know the local anatomy, and we are very lucky to have a very precise methodology with cone beam CT, which is a must for me in every case when I consider immediate implant placement. The goal is clear. You see, it has been said many times during these 4 days or 5 days of ITI World Symposium. We want to provide successful outcome, and here is predominantly the aesthetic outcome, and we also want to offer the best chances for a good long-term stability. And if you make mistakes during your surgical procedure, the patient might get a very successful outcome early, and then after 2 or 3 or 4 years, then the whole thing starts to be diminished, and then there is no long-term stability. That's why it's so important. Okay, so what are the important points from a surgical point of view? You see, I've shown this slide many years. You see, you have to select the appropriate implant. You have to put that implant in a correct prosthetic position. You see, restoration-driven implant place, famous paper by Garber and Belzer. And then, and that's very important, you have to have this implant completely embedded at completion of healing, not at day of surgery, because there is always a defect at day of surgery. At completion of healing, that means 2 or 3 months following surgery. Keratinized mucosa is most often present. So to re-establish a thick and a good height of buccal wall or facial wall, that is the important aspect for the procedures we can use in our patients. Now, what can you do at day of extraction? There are 3 options, and I want to go through very quickly. Immediate placement is one, we have heard already about it. The other one is extraction and spontaneous healing, to go for early placement after 4, 6, or 8 weeks, or you go for extraction and socket grafting for rich preservation. And then the placement can be done at 4 months, also called early placement, or then late placement, 6 months, or probably 2, 3, 4 years when this is a young patient of age 15. Now, immediate placement, we heard already by Maurizio very beautifully. You see, when we go to this table again, this is from the 2013 ITI Consensus Conference. These were the selection criteria we finally agreed on after heavy debates. Most important, a thick wall phenotype, at least 1 millimeter in thickness. Of course, enough bone to stabilize the implant, no acute infection. Today, this is done flapless, internal grafting. That's the important point. You see here the implant is always placed slightly to the palatal, and then you have this gap that has been discussed already by Maurizio, and you fill it up and do an internal grafting. The thick wall is important, so you don't get there a flattening because it's thick enough and it's not resolved by bundle bone resorption. So you see here a case I've done with Dr. Abu Ayyash in Bern. You see we started to do these procedures in 2017, and you see here an ideal case, as I would say, first premolar. You see a thick buccal wall, so I was very happy that we can do the planning, fully digital, and then of course a surgical stand is provided, and then you see here some surgical video slides, how the implant was inserted with excellent stability, internal grafting, and then the provisional restoration CAD-CAM produced before the surgery without any occlusal contact, and contact to neighboring teeth is inserted. We have used now for 3 years the BLT implant because it offered better primary stability. Then we go into initial healing phase, where the crown is not removed for at least 3 months, and then we go into final restoration, and you see the outcome will be very beautiful. And here now the patient I've seen after 18 months with an exceptional aesthetic outcome, very stable. You see the implant is rather deeply placed, and I can tell you I'm looking forward to get this implant with a machined top. We will call it probably the TLT implant, because you always get some bundle bone resorption at the tip of the extraction site, and you can then pre-compensate for that. The next one is immediate placement with partial extraction. That's something I have no experience. It's called the socket shield technique or partial extraction technique. A very interesting concept from a biological point of view, but I have to say, you see, there is a critical point, and is how predictable is the bone formation in the crestal area between the dentin of this root remnant and the implant. You see, this is not answered in long-term studies. We have systematic reviews with rather, let's say, quite promising data, but only short-term studies, and we are still waiting to get sound, at least 5-year studies to document the stability. Next one is now extraction and spontaneous healing for early placement. You see, this has been documented very well, and you see we decided to recommend it when there is a thin buccal wall or a damaged buccal wall, as in Lucy. You need enough bone apically, then after 4, 6, or 8 weeks to stabilize the implant. It's an open flap procedure, and you have to do contour augmentation with a primary closure. So you see here the extraction site, bundle bone resorption will reduce then about 3 to 8 millimeters of bone, depending how it is. And you see an ingrowth of soft tissue into the socket, which is a big advantage because you get a spontaneous soft tissue thickening. And then the implant surgery is done with an open flap, triangular flaps, and then you do this 2-layer composite graft bone augmentation, we call it contour augmentation. I'm sure then of Simon Jensen will go into the details of then the selection of the biomaterials. And here you see a case we did about 3 or 4 years ago with Professor Belzer. You see a heavy trauma case, no buccal wall at all, so like Lucy. And you see then after 8 weeks we did then here then implant placement, then contour augmentation, and a resorbable membrane, so there was no need to go back in to remove the membrane, and very important, primary closure, though in these cases never an immediate restoration. And look then the provisional and the final treatment outcome, a spectacular aesthetic outcome done by Professor Belzer and the top technician in Switzerland. 3 years, we have not seen the lady due to the pandemic. She will be more than 5 years this fall. We also can do that with 2 central incisors, and you see here a little bit more tricky, and you see also here excellent outcome, and you see here 3-year cone beams, how well we could re-establish a thick buccal bone wall at both implants. Now this procedure is well documented with 2 cohort studies in Bern in my department up to 2019, and you see here up to 10 years, and the data has been very, very satisfactory, very low risk, complication rates, and so on. The last one is now the socket grafting. So I show you only one case with a radicular cyst. So this is the late placement after 6 months. You see, this is this approach that you go later on. You see, we do it when there is no chance for immediate placement or no chance for early placement, or we do it now more also in elderly patients to minimize the surgical morbidity for the elderly patients. So the details have been beautifully presented by Maurizio, so I will not go into that. We just look forward to the discussion. Now here you see then one case, you see that is a radicular cyst, and we took the tooth off, and then we did a cystectomy 2 months later, and then here like a ridge preservation technique here with an open flap, and then implant placement. Case was done together with Julia Wittneben, and you see the 10-year follow-up, very stable in the periapical, and here we had a cone beam done at 6 years of follow-up. Before we come to the conclusion, I want to show you now a last case I did at the most recent a master course in Bern. You see, very tricky case. 2 teeth have to be removed, central and the lateral incisor, post-trauma done with Abu Ayyash, you see. And we have chosen here a socket grafting for the central incisor and a partial extraction case in terms of decoronation for the lateral to maintain the bone in between the 2 roots. You see, that's how it's done. Then we let it heal, and the patient got a resin-bonded bridge, so it was fixed. And then at 6 months, then we went back in with digital technology to do the planning with Samir. And then you see here from a master course, these are screenshots of the video clip. And you see everything was done as I have presented. Here you see the post-surgical radiograph. Here, most critical, the distancing between the 2 implants and the bone height between the 2 implants. At 8 weeks, the reopening procedure, and then Samir put 2 provisional crowns in, and you see here this case 4 days later, so we have the best chances to get an exceptional result with these 2 adjacent implants, as we all know, most difficult clinical situation you can have in the aesthetic zone. So we wait now 3 to 6 months, soft tissue conditioning, and then Samir will convert the case into full ceramic crowns. My conclusions. I have a minute left. I promise to be on time. You see, you as a clinician, you have a variety of treatment options. We have to stop to discuss this is the best and this is the best. All of them are well documented, can be used, but you have to choose the treatment that serves your patient the best. As we call it here, patient-centered implant dentistry. So you can go immediate, you can do early, or you can do socket grafting. I personally I'm using all 3 options. Immediate already 5 to 10%, slightly growing when I get the patients. I love to use it. Early placement now about 70 to 80%, but some decrease. And socket grafting I do predominantly in elderly patients to reduce the morbidity for the patients, you see. The case selection is the key. Case selection. It's based on a detailed risk assessment. Most important, anatomical risk factors that we heard so beautifully by Maurizio, and I also stressed it, of course, age is also a point. Okay, if you want to know more about the treatment concept we have in Bern, the GBR book is coming out, and I'm very happy to announce that the Bernese group with Tony Sloan and me has just established a close collaboration with ITI, so ITI members in the future have discounted tuition fees for these master classes where you can see these excellent live surgical procedures. Thank you very much.